enforcement. It's awfully expensive for the board to put investigators on planes to California whenever there's an issue with some.
But you volunteered twice.
I did.
Okay. And so far, this has not impacted nurse practitioners. It's just been 2 PAs. So when our regs get to OLRC or before they get out, we need to do APRNs and PAs, make sure they're both on there.
They're both in there.
Okay.
Yeah, they're both in there.
Okay.
And really, as much as anything, it was a leveling of the playing field.
Right.
Because a nurse practitioner or a PA that actually lived in the state of Mississippi, but had a collaborator or supervisor that was outside of the state of Mississippi, that collaborator or supervisor had to practice at least 20 hours by regulations as they already existed. But if they both lived outside of the state of Mississippi, that rule didn't apply. So we were really trying to level the playing field so that if both entities were outside of the state, that they had the same rules apply to them as if one that lived in the state and one that didn't live in the state.
We're not trying to complicate things. We're trying to make things clearer. And now,
So we've already addressed that.
We have.
really, we have the next thing.
I have a question on
Yes,
this.
sir.
I don't know if they're still doing it because they started before COVID, but Oshner's was treating hypertension on the coast.
Right.
And then, so their pharmacists would send the information, Bluetooth back. We gonna do anything about that?
But
Is that?
We approved that.
We
I'll
approve it.
approve that as a
I'm
board.
bringing it up again.
Yeah. Is it a problem?
Well, the problem is, and I don't practice on the coast, but one of the most common reasons for seeing a primary care doctor is hypertension.
Mhm.
So if they're doing that on all their algorithms, if you get sick, go see a family doctor. You know, it's, you know, so it's mission impossible.
So now I haven't reviewed that situation recently, so I'm just going off distant memory here. But my memory is that it was a very limited number of patients that maybe worked at a shipyard or something like that, that they were doing essentially a study to prove that hypertension could be managed through these protocols. Because and that's where the pharmacist comes in, is they have all the protocols in front of them. A doctor's still signing off of it. Signing off on it.
Doctor and Oshner's.
At Oshner's, yeah.
Who doesn't have a Mississippi license?
And I can tell you as a nephrologist who did hypertension for a long time, you can't just treat hypertension in all patients. I just think that's a model I'd like to do something about before delivery.
We had brought that up before. I
When
can't
they
see-
came and presented, and
Yeah.
the board actually approved
Yeah.
for them to do that.
It was supposed to be a very limited kind of a study. It was not full treatment forever and ever. We
I
can
don't remember-
revisit that. and
I
find
don't
out.
remember it just being a study. I remembered it
Okay,
for and ever and ever.
we can revisit that with the investigators and see what's going on.
Francis, we'll need to dig that up and see who the parties involved are.
Well, let's get to this other part, the reason I invited our executive director of the nursing board here today. And I'll throw this question out. This will perk up. She'll get off her cell phone. We need to understand if there's a viable reason to separate advanced practice registered nurses from certified registered CRNA. Because our rules get voluminous if we have to do two different things. How do y'all handle it? Y'all handle them as APRN?
According to the nurse practice law, CRNA, nurse practitioners in nursing class, are APRN.
Okay.
According to the nurse practice law,
Right.
there is no separation of the three as far as our regulation. They are all regulated according to the same rules and regulations that apply to APRN.
Yeah. All right, good. They've been demanding to be considered a separate entity.
Y'all
And-
gonna regulate it? That's off the record.
And here's why. This is an example. We have a surgical clinic on the coast who has 5, 6, 7 APRNs, and they had an anesthesiology group down there who was supervising the APRNs. They fired them. They hired an anesthesiologist in Louisiana, way over in Louisiana, to be their supervisor. He's never been to Mississippi, doesn't plan to come to Mississippi, doesn't come now at all. But they're using him as their supervisor, collaborate. Well, I don't know that that's the same with a CRNA. The anesthesiologist has to be closer, and we've talked about this. You can't have an anesthesiologist in Hernando with a CRNA in Biloxi. You can with an APRN, but you can with a CRNA. Their needs are more immediate in the operating room. And we're gonna have to make a regulation on this CRNA and where you're supervising, collaborating anesthesiologist needs to be.
So, and, as you know, they can collaborate with an anesthesiologist or surgeon in ambulatory surgery center. And if I'm not mistaken, our rules just say that that person has to be accessible. And we don't determine or define accessible. I understand what you're saying. It may be that they can pick up the phone, or do they have a backup on site? They're supposed to have a backup collaborator listed anyway. And most of them will have a list of anesthesiologists if they're in a hospital or surgical ambulatory surgery setting. They have a list of anesthesiologists that have been approved as their collaborating physicians because they operate under that group. So will one of those people be readily accessible in case of an emergency? I guess that's what I'm hearing you say. And so I just want to clarify that that's in our rules. We don't define readily accessible or accessible, really, in case something happens.
Well, in this case, if they had a group and there was somebody accessible from that group, but there's only one of these people, and he's in, where in Louisiana?
Somewhere near New Orleans.
Yeah,
Like
Pikeville,
Metairie or somewhere.
somewhere. And if there's a problem in the OR, he can't possibly get there.
So that, I mean, and that's where you were talking about this, we have to make room on this CRNA. Basically, you all have to determine how you want your position.
That's right.
We've talked about this before, a lot, and we had an argument whether the anesthesiologist has to be in-house or within 10 minutes or somewhere, but certainly I think in an adjoining state, doing his own practice is not going to be acceptable for a surgery center who's got 5 CRNAs actively doing anesthesia every day. That's just not good medicine. That's not safe.
You're also dealing with an acute, ongoing, intense situation. And if you're going to supervise somebody in that situation, you need to be available. And available in that situation means you're in the building.
In our hospital, the
Immediately
anesthesiologist is there during intubation and extubation, and is readily available on the OR suite if there's a problem. That's not true in this case.
I'm sorry. So I don't know if I need to put this on the record, off the record, off the record.
It's all.
It's all.
It's all public meeting.
Yeah.
Okay.
Phyllis, move on up.
Move on up where we can hear you.
Yeah, come on.
You can sit up here with us if you want to. We just need your input on some of this.
Okay, so I just wanted to say that, when I was at the VA, I was the administrative officer for the anesthesiology department. And so my job was to look at the practice of the CRNAs, make sure they were practicing accordingly do all the administrative work. And the anesthesiologist was always on site. I know that's a hospital setting, but that he or she was always on site at the initiation of any procedure, which is they have to be there when they initiate a procedure, and they need to go in prior to the person being put to sleep, to make sure everything has been done appropriately. So I just wanted to bring that, to y'all. I know y'all understand, but the situation that you all were talking about, I was trying to figure out, well, are they doing telehealth surgery or?
And so, the situation is you got a 7-person CRNA group in the ambulatory surgery center that is collaborating with a physician essentially in New Orleans. And the surgeons are not accepting the responsibility for collaborating with those CRNAs either. So the surgeons are not signing off on the charts. The surgeons are accepting no responsibility for the anesthesia side of the screen. And so that's
verification.
Yeah.
They really don't have anybody there.
in it.
Basically,
So
and the surgeon is not a backup.
So this is an administrative problem for the facility.
Yeah.
The surgeons are operating under the present rules saying we're not
I'm not
gonna
gonna do it.
supervise. And so the facility doesn't have anybody to do so.
And it continues to operate.
Continues to operate.
We had this occur in Greenwood, Mississippi.
Yep.
And here's how we solved it. There was an Ole Miss graduate and a Mississippi State graduate who were anesthesiologists, and they had 5 CRNAs. Well, when the Egg Bowl came around, or when both teams had a home game, the anesthesiologist went to the football game. Well, that left the CRNAs there alone. And the surgeons in Greenwood refused to sign the thing too. So we just told the anesthesiologist, one of you is going to miss a game because you can't both go. And we solved that problem. So we may have to do something down here, like saying, you can't hire somebody in another state. You got to have somebody readily available. Now, readily available is going to be the true term.
With Charlie, Dr. Miles,
Yes.
what we need to remember is we regulate the anesthesiologist.
Right.
We don't regulate the nurse anesthetist. We don't regulate the facility.
We regulate the surgeons.
And the surgeons, but we can't tell the surgeons that they have to practice anesthesia either.
I don't think that would be appropriate.
So,
If they want to, they can. If they don't,
I think the path that I would recommend we go down is telling the anesthesiologist that if you're going to collaborate with nurse practitioners, you have to be immediately available.
Or
Sure.
CRNAs.
CRNAs who are not, by definition,
What did
at
I
the state
say?
You
nursing
said nurse
board.
practitioners.
I meant
And that's where we're.
I just,
Well, also
look,
getting
whoever you're gonna collaborate with, how about that?
So,
Yeah.
the next question I have is, because I'm listening to this, we have CRNA practices in Mississippi. I need the name of that CRNA to see who they have listed as their collaborator.
We can get those for you.
And what their practice site is. And so, because we have to jointly approve, but not jointly, but we have to get with you all to make sure that person that they have listed has an unencumbered Mississippi license. So that's why I'm saying, why do they not have a backup? But they have to have a listing of, they don't have to have a backup, it's highly encouraged they do. But normally they operate in a facility of that nature. There's a listing of people that they have as their collaborators and backup collaborating positions.
Well,
So
this
I
is
would
not a
need to look
hospital.
more- I would need to look more into that from our perspective. But what you're saying is right, that you all would can make any rules and
Yeah.
regulations you want to regarding your position.
Yeah, and I'd be surprised if their liability insurance is with Macomb, if Macomb would be real happy with them operating without anesthesia available and not signing the liability thing.
I just don't understand how that could be considered in the best interest of the patients, because a lot of times those complications arise and there are definitely some high-risk situations where you can anticipate complications, but we all know that they can occur when you least expect them. And that's really not in the best interest of the patient to scurry around in the middle of anesthesia. I mean, the anesthesia complications are one of the major issues with mortality around surgical procedures, or not even related to the procedure itself, but with anesthesia. So,
Yeah. The way I understand this, Phyllis, is that the person who signed the protocol has missed your license, never leaves Louisiana, and is not associated with the practice at all. He is the medical director of the company, which is,
an administrative.
Well,
He's
and
administrative
he's the one that's
somebody.
signing off on the charts.
Yeah. If he signs off on the charts, and let's
Well,
just
he
say
doesn't
it's a
sign the
Medicare
charts.
chart,
He
and he
signed-
never comes over there, he's got bigger problems.
he doesn't sign the charts. He signs their nursing protocol that goes
Really?
back to the board of nursing.
Nobody signs the charts.
So you're saying that they have a medical director that's over this facility?
Within the company,
And within that company, and that person is?
he signs protocol for this group and signs protocol for that group and signs protocol for that group, be they Georgia, Mississippi, Louisiana,
He's an anesthesiologist.
Yeah. who is their medical director.
They're just dodging rules.
And
That's his
administrative,
corporate- That's his
I thought he
corporate
was signing
title.
off on their OR forms, that's the
I thought
anesthesiologist.
so too.
He could have been, but the attitude that we got, and Phyllis Floyd went with Harry to go talk to this group before, so you're loosely aware. So in any case, the attitude was that this is normal. This is, what's the problem here? This is the normal procedure across the country. What's your problem with this? And of course, we just went asking questions about how does this work? And that was the response we got.
Mississippi doesn't go across.
That's right.
That's right.
And
Well,
this is,
you
this
know-
is one of many of these things like we ran across yesterday. People who want to make companies that
Or leeches.
stick their tentacles in here and leach out money.
So,
And
okay, so that great.
It's
Medical director of a corporate entity.
Yeah.
Yeah.
And that person is signing off basically on the practice agreement.
yeah,
Normally, when they sign off on the practice agreement, they should be collaborating physicians, they should be practicing.
Exactly.
That particular individual,
mhm,
okay?
right.
So I do know that, we as the board, if there is a group that employs a group of CRNAs, or anesthesiologists, and that CRNA as a contractor works with that company, the medical director is considered the entity that, the administrative entity, so to speak. However, they normally have those other collaborating or backup positions that the anesthesiologist, the CRNA can collaborate with basically on site.
Yeah.
So what I'm hearing, this person is not on
No.
site. The ones that we have dealt with basically have, if they sign up on this agreement, they accept the responsibility as a
Yeah.
collaborating physician.
I sign a whole bunch of these things all the time. Yeah. And because I'm taking responsibility and I'm backing up.
You know, we can beat this
No.
thing
Yeah.
into the ground. Let me suggest that the board write a letter to the surgeons in this group and say, hey, you got a problem here. Are you aware? They are, but this would be a official notice. We can also send a letter to the anesthesiologist saying, what you're doing, we don't agree with. And if you continue doing it, you're gonna have to come up here. Well, he need probably just come up and talk to us anyway.
And just for the record, the surgeons are doing nothing wrong.
I know, but they need to be made aware that this is not.
They've been
kosher.
told they have turnkey deal and no responsibility. and
Yeah,
no
they've been told they
liability.
have no responsibility, that this anesthesia person takes care of all the liability and everything. He can't. There's no
So-
way.
So what exactly is there a position or a distinction between an administrative collaboration and a clinical collaboration?
Yes,
Absolutely.
absolutely.
I mean, I get that there is one in our brains, but my question is, is there a such thing that exists on paper?
Well,
It
there's-
should be.
The
One is
administrative person
active
has to do with
collaboration.
budget and protocol.
Well,
And the
does this-
other has to do with the day-to-day care of
Because the
patients.
question is
So,
that,
so all our regulations are written for clinical practice, not for administration,
Right.
would be the answer to that.
So-
So
but I guess the reason I asked that question is that, does that create a loophole that needs to be addressed or closed, is the question? Or
Well, this guy.
because I think it's intuitive until somebody interprets it in a non-intuitive way.
Is in this case.
It's intuitive until it's not.
So the question is, do we visit him again and say, we don't think this is kosher, you need to shape up, or do we tighten up the rules?
It sounds like the CRNAs aren't meeting the requirement of having an accessible collaborator.
But remember, we don't define accessible. You might be
What
telephone
accessible
call.
means accessible.
It should.
90 miles a day, 90
90
miles away in the operating room is
But
not
I've asked
accessible.
that question and it says, in our rules, and I'll have to go back, because maybe we need to tighten up ours. But it says that it needs to be accessible, and that could be, phone call, that could be, me FaceTiming somebody and saying, hey, this is what I got going on, this is HIPAA compliant. So we don't define accessible. And if you all are gonna define accessible for your physician, then that would impact what the CRNA has to do at that point, because they would have to abide by whatever you all put in your rules, because we're a collaborative state.
Well, if you're collaborating with a doctor treating hypertension in Greenville, and the nurse practitioner in Greenville, nurse practitioner calls you up and says, I got this patient, he's not responding to this, or this. Well, you can over the phone tell that nurse practitioner, well, in my experience, that doesn't work that well, so-and-so, so-and-so. But if you got in a patient under anesthesia that starts to go bad, and you call your collaborating physician in Louisiana, there's no way they can collaborate with you. And that's not collaboration. That's
Yeah.
just.
Are there other anesthesiologists there at this surgery?
No.
center?
No,
They were
And so-
given one of two choices to do. Do you want an anesthesiologist on site, or do you not want an anesthesiologist on site? It's cheaper if you don't have one. And so the administrator went the cheap route.
So we need to. for my
I just had
two
some communication about, y'all were asking about who actually signs off on what, so I was communicating with Harry. So the administrator for the surgery center is a Rick Lawanang, I guess that's how you say his name. He has stated that CRNAs are independent, those are his words, direct quote, and that surgeons do not sign off on the anesthesia portions or anything else concerning anything the CRNAs do. Now, that's coming from the administration of the surgery center telling the surgeon, you don't need to worry about it, we got it covered.
That
Well, I'm
was a
sorry,
reason-
but when a CRNA tells a recovery room nurse that go ahead and give some labetalol for that blood pressure, somebody like me comes behind them and has to co-sign that order.
All of the collaboration information, according to the administration, is signed off and handled by the anesthesiologist. And he is located in Slidell. And interestingly enough, on his renewal for 2021, he claimed nobody as
Oh.
collaboration.
All right, then.
So
Well, there you go.
there you have
looks
it.
like we both got a problem.
So he thinks they're independent too, apparently.
CRNAs are not independent.
Is that not correct?
They're considered APRNs, and last I checked in the state of Mississippi, we are a collaborative state.
They're
Yeah.
considered APRNs.
They are by law, APRN,
We talked about that yesterday.
Okay,
by law, that's in the law.
okay, so,
They are an advanced
okay,
practice registered nurse. That covers them. I mean,
Just like me, in
Yeah.
advanced practice.
advanced.
registered nurse.
yeah,
You're
And I
advanced in a
have to
different area.
operate under and within my scope of practice under the laws of the state of Mississippi for what nurses and advanced practice nurses can practice on.
So it sounds like we need to write this anesthesiologist a letter. Maybe write the surgeons a letter, and you might need to write the CRNAs a letter. That this is not, yeah,
Well,
this
and what I can do is have a meeting with this anesthesiologist
That'd be good.
here at the board.
Yeah.
Yeah.
Um,
I think we've got a gap too in how we cover the operation.
Well, I do think
Because
that-
that's in our rules and regs.
we
And
could
this is
tighten
an
up our
area where
regulations.
Yeah, we
they call me and say, hey, come look at this rhythm, and you walk in, they're pumping the chest. And the things they call me for are not things they can just talk to me on the telephone about.
that's the
Well,
point.
Yeah.
exactly, and because I mean, we work with CRNAs, our institution all the time, they are exceptionally well-trained and very good at what they do. And when they have a problem, it's a problem.
That's right.
And that usually is not something where an anesthesiologist walks in and waves this magic wand and everything goes away right away. Like when they're calling for backup, like the ship's going down, we're taking on water, and we need
Yeah.
somebody here
And
yesterday.
in all
And it's not
fairness-
just your mind, it's your hands they
And I was
need.
fixing to say, in all fairness, it's not just CRNAs that need backup. Sometimes anesthesiologists need a second anesthesiologist in the room.
Right.
You know, I mean, so,
They can call them nephrologists.
the solution to this would be
And when the
if
nephrologist
the
is
surgeon
here,
in this surgical center would sign on to be the captain of the ship, which they've refused to do.
right.
Well, I think they were told they don't have to. I don't know if they refused or not.
I don't
They were,
think-
probably
they were
don't
just told, don't worry about
Is
it.
this
Yeah.
just,
Don't worry about it.
I
We
mean, do
got
we
it.
feel like this is just like maybe bad information that's been perpetuated and it's coming from a high place?
Oh, no,
and it's
we've,
just-
con-
The bad
we confirmed
information's
that
coming from
information.
YPS, the company that's supplying them, and their attorney
okay.
talking to the administrator who wants to believe all this so he can save some money.
Well, he should just say a bunch.
Yeah. Or lose a bunch. Anyway, this is why we wanted you here to tell you about
So
these two problems.
may I recommend that Phyllis, Stan, Jonathan, and myself get together and put together some recommended regulations in this area to present to the Rules and Regs Committee at the May board meeting.
Yeah, I think that's good, but I think somebody needs to notify this
I'll
service
do
center
that
that
in the meantime.
there's
Yeah.
a problem.
He needs to come before the EC to explain why his re-app says one thing and his practice is another.
Well, we can do that. I mean, you
So
want
you
both
wanna
visits,
call
one
both
with
of
me
them?
and one with EC, or just go straight to EC with it?
Bring it straight to EC.
Okay.
Jonathan,
This is a
is the
real
administrator of this surgery center a physician, or
Let me
MBA,
look
or
at the credentials.
a
that it's on the
dentist or-
signature. Um,
He's an,
RN,
he's an
MSN,
MBA.
MPH.
aha, then Phyllis, that's another problem.
Oh.
But not if he's not practicing.
Right.
Right.
Well, he's not
I mean,
practicing.
if he's working as an administrator and not as an RN,
Yeah.
Phyllis doesn't really have any.
Well, he's giving
That-
bad
that would be,
advice.
You know, that's under the auspices of the facility, his
Yeah.
employer, as to what he's hired to do or she.
But if part of his job requirement is that he be an RN and he's given erroneous bad information, you might want to say something.
Well, that's like I was just telling John that, because it seems like they need some education as to what there's, what the laws are, pretty
Mhm.
much, and that's what's surprising to me, that, of what the response was from that individual. Then again, I'm trying to see where did that information come from, and it seems like there is some erroneous information being passed.
Sounds like it's coming from the attorney of this group who is not based in either Louisiana or Mississippi.
Yeah, and we see that a lot with some of the, I guess some of the attorneys that don't focus a lot on the administrative part of the administrative code kind of stuff, because
Yeah.
they'll look at different statutes and not really focus on the things that matter in this particular domain. So maybe that's a part of it too. Who knows?
We've been through this battle before with the pain clinic administration out of Tennessee or whatever. They were setting up a bunch of pain clinics and they weren't abiding by anything. They were just setting up clinics.
Well, we had people yesterday want to set up telemedicine from over there to have a
So the two things.
PA
we
do
found-
telemedicine to here, and it's, everybody's
As I
looking for a way to
understand
ramp
the
up.
telemedicine, our relaxed rules due to COVID are now unrelaxed.
Not completely. So as far as out-of-state physicians are concerned, the answer is yes. As far as in-state physicians are concerned, the answer is no.
So
They're still
those things
relaxed.
that we allowed to be in place to kind of help facilitate care within the state for practicing clinicians are still, they still are
Yes.
in effect. Okay.
They're probably remaining.
Mhm.
And they will remain in effect. What we have required is out-of-state physicians actually get a license in Mississippi if you want to continue to do telemedicine in Mississippi, which I think is perfectly reasonable.
What you have to understand also, CMS has relaxed the supervision requirements. Medicare.
But
And those relaxations remain in effect and may remain in effect until the end of 2021.
But they say that's up to each state to decide
it
whether or
is,
not
depends
to
on
do
state.
that. And each of us kind of looked at it and said, we're not in New York, we don't have that need. We had people sitting on their hands rather than people needing to expand scope. So,
Back in 2019, Governor Bryant did not opt out.
he did not expand
Right.
Well,
temporary scope.
there's a bill in the legislature to relax the telemedicine.
The bill in the legislature has nothing to do with actual practice of medicine. It has to do with reimbursement for telemedicine.
So are these audio-only telemedicine visits are they gonna go away when the governor ends the state of emergency?
They were there
Well,
before the state of emergency
yeah.
started.
Mhm.
But I think what Dr. Livencott's asking is, does our relaxation of the telemedicine law, rules and regs remain in effect once the governor ends the state of emergency? And the answer would be no. Because all of the proclamations say that when the state of emergency ends, our relaxation of the telemedicine regulations end. So if we want them to continue to be relaxed, so to speak, we need to
We'll
change.
have to change them.
Yeah.
And the real relaxation came from out-of-state physicians who already had a relationship with the patient. That was the biggest.
That was the biggest one, which
Biggest
we've
one.
already ended. But there is some language in there as far as prescribing controlled substances and stuff like that, that was relaxed
Yeah.
with these proclamations that we probably need to take a look at and consider making those permanent.
Do the telemedicine regs require there's no audio-only telemedicine, right? It has to be like HIPAA compliant, audio visual, does it have to be provider to provider or?
You're talking about the way the regulations currently exist.
Yeah.
There is no audio only as the regulations currently exist.
But it's going on.
It's going on under the state of emergency.
Under the state of emergency. And if we want,
CMS has approved it.
it has, but as we mentioned earlier, it says based on state laws. I mean, so we still get the final say in it, right? As far as our state goes.
Blue Cross Blue Shield doesn't reimburse for it, but CMS does.
And that's what the whole.
Yep.
That's what the
telemedicine
legislative thing's
regulation
about.
is about.
Mhm.
Okay. So just remember, that's just a whole separate thing than what we get involved in.
We aren't involved in that at all.
Right, that's correct. We don't want to be involved.
Do
I
not
was
want
gonna
to be
say,
involved.
you say that as though it's a bad thing. I don't know that that's a bad thing.
I don't know either. I don't care. I don't want us to get involved, and that's just quicksand up to here. I don't want to mess with that.
Well, there are a lot of Mississippi doctors that having tried telemedicine find some real advantages.
Oh, yeah.
Patients are all over.
Yeah.
What I find though is many patients, if they're doing it from home, don't have a CUC meet type operation with FaceTime.
Right.
So it's got to be auditory, because they just don't have the computer skills. So I think audio.
Nobody's disagreeing with that. I'm just telling you what the regulations currently say.
Yeah, I'm just saying, so it'd be nice to, on a go-forward basis, start thinking through the rules a little bit.
If you're a Mississippi physician.
You know,
Based.
you can go to pay your gas bill now, and somebody will say, would you like to talk to our doctor? Any problem?
You can watch the
Yeah,
NCAA.
you can talk to him right here.
You know, those
He'll tell
things,
you what-
those
You can watch the
video things
NCAA
we,
tournament while you're looking at gas.
All right.
Okay, is there anything else we need to go through? But we got the ED of the Board of Nursing here to know where some of this problem lies, and I think going forward in making rules and regs, we conjoin APRN, CRN, and it'll make writing our regulations simpler.
Well, do we need to, if that's already defined, do we have to, I mean?
We have had,
do
the
we-
CRNAs have come and said, we're a different entity.
Can Phyllis and I work on that? and
Yeah,
Get back
go
to y'all.
I was just like, do
Please.
we
I
think that
have
would
to
be
do
good.
that? 'Cause,
Please.
She just said it was the same, so.
We'd rather y'all take care of that. Come tell us what you find out.
All right.
Thank you for coming, Phyllis. We're pleased that you could,
It's always good to see you, Phyllis.
yes.
Oh,
Come
yeah,
see us
you know,
more.
good to
In fact,
see you.
Y'all only invite me when you want me to sell the house.
I'd like to buy you breakfast. Come on in.
It's back in the back.
I might take you up on that.
Come on.
You
I'll
have
get
to
you a
walk
cup of
around the
coffee
coffee
and a
bean.
salad.
I
Oh,
picked
yeah.
those coffee beans.
Aren't they
And I
delicious?
couldn't get them out. I turned it upside down and I spilled 1,000 of them.
Yeah, David, you don't
They're
have
all-
coffee beans.
so they're all
anymore,
dirty
just
now?
Dr. House.
No, I-
Come on, this
I,
side.
I saved
What
some
made
just
you
for you.
decide to turn it
Yes.
upside down? Just out of curiosity.
Because I thought the bottom was clogged.
You
I
have
was
any
gonna see what
idea-
was in the bottom.
Any idea how special these things are to everybody?
I know they are special.
Do you remember the little candy machines that used to be in the stores? Like
Yeah.
when you went to Kmart, and you could just put the little nickel in the machine and turn it?